Hello, hello. Welcome again to the virtual classroom. I'm your host, Jim Stringham, and as far as you know, I'm dressed nicely and I'm clean shaven and not sitting here in my pajamas. So let's not go there. This is my lecture on clinical aspects of vision. I'm going to first start with something that we've already covered, but I thought just in the interest of simulating an eye exam, this is kind of how it goes. You start with getting your eyes tested, refractive errors. I'm not unaware of the fact that we've already covered this, so I'll go through it relatively quickly. But I wanted to kind of start from the start, talking about the different states of refractive status of the eye, emmetropia being one. This is when light from the distance is in focus on the retina. The most common refractive error, myopia, caused when the eyeball, generally speaking, is too long. It can occur as well if the cornea is too steep, focusing light in front of the retina as opposed to on the retina. And of course, you need to back that focal point up to be in focus on the retina, and how you do that is with lenses. Okay, they're called negative lenses. They move the focal point back. All right, next case, as we've learned, is hyperopia. Eyeball typically is too short. The cornea can also be too shallow. Most often, again, the eyeball shape is what determines this refractive state. And again, you might not notice this condition until you get a little older, when your lens can't actually bend and bring that focal point into register with the retina. Presbyopia. Again, I mentioned hardening of the lens, usually around the age of 40 to 45. I happen to be experiencing a little bit of this. I can still read near work, but it's becoming more difficult. It's a little frustrating. My arms are getting to be too short. That's hardening of the lens with age. Natural, nobody's immune to it. There's no way around it. Ideally, you want the light from the distance, objects in the distance, to be in focus, and then you can always pop on a little help, little reading glasses or whatever to see things up close. Okay, astigmatism, again, we've covered this. The cornea is not perfectly round, not perfectly spherical. It's just ever so slightly misshapen, usually in one axis or another. And I've showed you guys this bicycle spoke chart where the one of the lines should appear. If you've got a mild astigmatism, you'll see one of the lines darker than the others, and then you can rotate your head around and make that line also rotate. And that just illustrates the fact that in one in one axis there's a defocus, and so that'll manifest as a darker line in the bicycles. We may have seen these pictures. I think I showed them to you. Corneal topography, and you can see this is a plot. It looks a little like a weather map, but it's a plot of the focusing power of the eye as a function of the scan across the cornea. And these are, on the top there, those are unusual patterns. We've got, generally speaking, you see a slightly stronger, denoted by red, sort of a focusing power in the very top, the very peak of the cornea, and it falls off, it drops off pretty precipitously with eccentricity, okay, working outside. And these in the top, show some odd patterns. Could have been produced by either disease or injury. Okay, like for instance, the upper right, you rarely see the darker colors there in the center, near the center of the cornea, because typically we see that reversed. So there may be a slight flattening or a pit, in fact, in the cornea there, which of course would be some pathology you've got to deal with. The lower pictures are more common. Astigmatic refractive errors you see in that one dimension, roughly 90 degrees in each eye, and that's fairly common. It looks bizarre, but that person probably has fairly normal vision, just needs a little correction for astigmatism. 20/20 vision, what does it mean? It's a standard. Okay, it's just kind of silly and circular. It's when you have 20/20, you can see from 20 feet away what a normal person, a person with normal vision, can see from 20 feet. It's a little bit silly, but it's a standard, and there's a standard letter size that's used from 20 feet. If you can resolve that, then you have 20/20 vision. Okay, hopefully that makes sense. Otherwise, it's just fractions. So 20/60 vision, you have 1/3 the acuity. 20/60, of course, reduces down to 1/3. And practically speaking, it means you can see, you'd have to scoot up. Somebody with 20/20 would have to scoot up to 20 feet, or could scoot back to 60 feet to see what you could see from 20 feet. So obviously your vision's worse. You are the numerator, normal's the denominator. So if you're 20/10, then you can stand at 20 feet, whereas somebody from 20/20 has to move up to 10 feet to see what you can see. So your vision is obviously better if you've got 20/10 vision or 20/15. I imagine many of you have, if not 20/20, 20/15 or 20/12 or something like that in one or two eyes. Legal blindness, 2200, so you've got 1/10 the vision. Somebody with 20/20 could back up to 200 feet to see what you could see at 20, to see what you have to see at 20 feet. You have to scoot up to 20 feet to see, I should say. The angle of the visual field is important, 20 degrees or less in the better eye. So you may have excellent acuity, like 20/20 or better, but you've only got 20 degrees of vision, which is a small bit of field. So obviously you're not going to be driving a car, not going to be doing anything that's terribly important that relies on your vision. All right. So normally, vision that's worse than 20/20, we wear contacts or glasses. All right. Glasses, I may say the word spectacles as well, because glasses obviously can refer to a water glass or something like that. LASIK, we watched the LASIK video in class. I've also put this slide up for your reference, because I think that, LASIK is a very common clinical technique now. And so maybe familiarize yourself, maybe watch the video. It's 5 or 6, 7 minutes, something like that. And that tours very well. So I think the next slide has that link. The eye chart, you can see just the general progression. Generally speaking, if you can see that big E from 20 feet away and that's all, uncorrected, you've got 2200 vision. Okay? And again, it's calibrated to a specific distance from the chart. Most people, they say, well, gosh, my eyes are bad. And the fact is that your eyes are really technically not bad, quote unquote, if you've got a refractive error that can be corrected by glasses or contacts. Not a big deal. Your eye is probably perfectly healthy. It's just slightly out of round, misshapen, longer, shorter, what have you. When you need to worry is when you've got a retinal issue. So if you can't get the light into focus, you can't focus these letters, for instance, on a chart at distance, then you've got an issue. Then you've got other, the more important stuff. The retina is damaged, or perhaps, further on upstream, LGN, visual cortex, something like that. But don't panic. Don't think that your eyes are weak or bad or whatever if you need spectacles or contacts. That's usually not the case. And again, as you'll see, if you revisit the LASIK surgery video, I've got the link in here. It's all due to, in terms of focusing, the medium that you pass light through and the speed of light that it passes, that is light speed through that medium. In air, of course, 186,000 miles per second. Water, it slows down a little. Glass. So depending on the distance that light has to travel through a piece of glass, so a magnifying glass, for instance, you'll notice, or you'll remember, that it's thicker in the middle and it tapers down to the edges. So light has to travel through the thicker part longer, and so it slows down more. It's an appreciable amount that it slows down. The thin parts of the glass, of course, they can travel through relative to the light in the center, the rays, faster. And so they go through and they bend slightly, and then they all catch up at one focal point. And if you're focusing light, that'll manifest as a bright spot of light. And that's essentially the basics of refraction, bending light. You can bend it the other way. You can send the light rays in opposite, sort of away from each other, not necessarily focused. So here's the link to the video. I'm not going to show it directly to you, but I've posted this slideshow and of course you have it from another slideshow I believe that we did earlier in the semester. I would definitely watch this again. It's 5 or 6 minutes, not too big of a deal in terms of time commitment, and just pay close attention to the strategies, the techniques, and of course why. Why do we take corneal material? How do we reshape it to correct for myopia, hyperopia, that kind of thing. Onward and upward here, cataract. You guys have heard of cataracts, I'm sure. Well, cataract is simply when the lens that you're born with sits right behind your iris. It becomes very cloudy. It actually yellows with age, and that's just the denaturing of the proteins that make up the lens. And you see, when you're 6 months old, there in the upper left, the lens is virtually transparent, and it transmits all light, practically. All visible light, that is. The yellowing that you start to see at age even early as 35, 40, 45 years old, that's normal. And you might think, gosh, it looks like a dirty windshield. I don't want to look through that. Well, the visual system compensates a little bit for that yellow. The yellow filters some of the blue light that is incident on the eye, and that's actually a good thing, blue light being highly energetic, and so you're protecting your retina somewhat as your lens yellows. And so it's a bit worrisome as an infant or a young child. You're out playing in the sun, and you may be doing some damage to your retina if you're not careful. And so sunglasses are good for that. And I'll get to some aspects of your diet that can help with that as well, eating leafy greens and whatnot. Well, anyway, you get to be 60, 70 years old, and that thing starts looking dark yellow or brown. It becomes too much for the overall visual system to compensate for. It can't correct for that, and light hits it and it scatters like a dirty windshield, and it makes vision virtually impossible, washes out everything, and so you can't see through it. So what do? You have surgery to get the thing removed. And by the way, this surgery is the most frequently performed operation in the U.S. each year. Thousands of these things performed every week in the United States. It is one of the leading causes of blindness in the world, as I note up here in the first block of text. But that's simply because the technology is not available, the surgical technology is not available everywhere throughout the world. Trust me, though, I've assisted on these surgeries. They are 15 or 20 minutes long. Take out your cataract, pop a new synthetic lens in, nice and clear, you're good to go. Really, literally, it's about 3 or 4 days recovery, not too difficult at all, and you've got yourself a nice clear lens that's often calculated to bend the light just right, so that it's like having a pair of glasses on inside your eyes. That's cool. All right, cataracts usually, again, manifest in older age, a little older than 65, usually. Sometimes they can be found in young people on occasion. Sugar cataracts from diabetes. I'll show some pictures here in a second. Poisons. Premature infants can develop cataracts. It's oxidative stress that those preemies are under that can bring on a cataract. All right, and I mentioned diabetes. If your blood sugar is too high, that can just turn it into a white cataract, which is pretty wild. I've seen somebody wander into the eye clinic with diabetic cataracts, and it's pretty scary. I'll show you what it looks like here in a second. How do you remove a cataract? Well, a couple of techniques. Phacoemulsification is we use an ultrasonic probe to break up the lens, because remember, it's usually hard by this time in older age. Break it up and vacuum it out. Is that not crazy? It sounds insane. Like, wow, really? In my eye? It is a delicate, delicate thing, this eye, and you don't want to mess with the pressure in the eye. You don't want to certainly mess with the retina. Super delicate. But in the anterior chamber of the eye here, where the lens is located, you've got a relatively closed system. You can kind of mess around in there a little, and you'll see from these surgeries, these links that I've given you, it can appear to be aggressive, but it actually is safe. Like I said, I've seen these surgeries firsthand, and they are. The new lens you see here on the bottom picture, it's got those strands, those hooks, and they hook into the existing ciliary processes, the muscles that normally would suspend the natural, the crystalline lens. You hook it in there and it sits in place. And it kind of sits in its own, the bag that the lens, the natural lens, sat in before it got removed. Okay. Now this is fairly recent, this surgery. Again, highly successful, very frequent surgery. But in the 1940s through 1970, cataracts could be removed. We did not have intraocular lens technology, the new synthetic lens. Okay, so what does your lens do? In part, it focuses light. It does about 20–25% of the focusing for the eye. Well, you lose that, you've got to compensate with these massive glasses. And my grandfather actually had to wear these glasses, and they were glasses, so they were heavy, big, thick lenses. This is where the term Coke bottle glasses, if you've ever heard that, that's where it came from. That's just an extra thick lens. It's kind of like a magnifying glass you have to wear on the outside of your eye. He didn't care. He was happy as a clam to have vision again because he had apparently pretty nasty cataracts. People tried to convince him after, because he was alive when the technology for IOLs came into play, but he was too used to his glasses and didn't mind so much. So he never did get the IOLs put in, those synthetic lenses. Okay. These days, of course, you've got a couple of techniques. You put in this IOL. You go through a pre-operative workup where we calculate your lens power in your eye, the length of your eyeball, how much, the thickness of your cornea, all sorts of things that go into calculating exactly what the best lens power would be to put inside your eye. Isn't that cool? It's not like calculating the power of the glasses, spectacles that you put on. This is putting it into your eye, so you can customize your vision by putting on glasses effectively inside your eye. Okay, and this IOL may actually be better than the natural lens at focusing light. Certainly, it's clearer than the cataract, no doubt. These are examples of cataracts. I mentioned a milky white diabetic cataract. You see a couple examples of that. The lower right there is a nuclear cataract. It's in the nucleus, the center of the lens. The upper left there, that's probably a mixture. It looks almost like a broken windshield. Cataracts can manifest again from lots of different, dietary exposure problems, too much blood sugar, poisons, and those kinds of things. Some of these are, the one in the upper right is a somewhat normal cataract. You can see the yellowish, milkyish. That thing is ripe. It's ready to go. You need to get rid of these things. Take them out. And it's not going to hurt your eye if you leave them in, typically, but certainly your vision would improve if you get those things out of the way. All right, whoa, grody. You're going to see in the link on the next couple of slides, I've got a couple of links for you, cataract surgeries. And indeed, this is what it looks like. It appears somewhat aggressive. You go in there, and that ultrasonic probe that you see right now is breaking up the cataract, and then those chunks, those bits, are vacuumed up. That's the phaco technique. This, the movie, the video, shows the extracapsular technique for removing a cataract. And as I've noted here, not for the squeamish. It's where you actually cut a section of the eye open. You remove the entire lens, plop it out. Okay, and it's not as frequently performed, slightly easier surgery. But what happens when you squeeze the whole lens out of the eye? It increases the intraocular pressure greatly, and so that's dangerous for the retina. Okay, it's kind of like an acute attack of glaucoma where the pressure goes up super high, and we'll discuss glaucoma in a few minutes here. Okay, so you don't want to do this one, but I think it's interesting to watch. At least I think it's interesting. If you don't have the stomach for it, then cover your eyes, peek through your fingers, do what you got to do. All right, then the phacoemulsification that I mentioned earlier, discussed. This is a neat surgical technique. Again, ultrasound, the same kind of technology that's used to image, say, a fetus inside the mother's womb. Same kind of thing, except this is just a probe that is used to break up the hard lens, okay, the cataract. And then you suck it out of there. Okay, and there's an exchange of fluid that's exactly the same, so you're not just vacuuming out everything from the eyeball. Again, it just takes place in the anterior chamber, the front chamber of the eye. Interesting. Okay, glaucoma. Now this is another common disorder. It's an increased, the symptom of glaucoma is increased intraocular pressure. So the eye is pressurized slightly, and normal pressures range from about 14 or 15 millimeters of mercury up to maybe 20 at the most, and that pressure just maintains, shape of the eyeball. It's caused by the fluid flow. There's a production of fluid from the ciliary bodies. You see where the arrow emerges from that green arrow in the illustration there. It flows in, gives us nice, clear anterior aqueous humor, and so that's, you want that to be clear. You want to look through a nice, clear bunch of fluid in the front and maintain a decent amount of pressure on the cornea so that it stays popped out like it should. You increase the pressure in the eye, and of course that impinges on the optic disc, the optic nerve head, and it can pinch those ganglion cells there. And of course, it's this neural tissue. You pinch it off too much, you damage it, it can't regenerate. It's damaged for good. Nerve cells don't perform mitosis, not in 99.9% of cases. Certainly the eye is one of those cases. All right. Another manifestation, visually anyway, is visual field loss. You'll see an arc, flashes of light. If you start seeing that stuff and it's unexplained by actual stuff happening in the environment, in your real world, get to an eye doctor as fast as you can, because you may be having an acute attack of glaucoma. It happens sometimes. Okay, and if it's not treated pretty soon, you could lose part of your visual field permanently. It could happen. Okay. Good news about glaucoma is that it's treated quite easily and effectively by drops that either decrease the amount of fluid that's produced by the eye, the ciliary body. It can also relax vessels, allow the channels to flow a little more freely. It's kind of like a kinked hose versus a hose that's straightened out, and it can flow much more easily. Little YouTube link. I hope that link is still valid because it's talking about an iridotomy. If it doesn't work, then maybe you can search. This is the one I didn't actually check before I started the presentation. This is where, and I've seen this, I had a woman come in to the clinic, and I took her in. She said her eye was kind of hurting. It felt tight, and so I measured her intraocular pressure. This was in one eye, and it was 63 millimeters of mercury, which is the highest I had ever measured. And I said, oh, good grief. And so I measured again to double check very quickly. Indeed, it was 63 or 64 millimeters of mercury. And so I said, come with me. And I grabbed one of the ophthalmologists. I said, she's got, this, symptoms of flashing lights and, incredibly high IOP. And so I grabbed him. He ran her into the laser room and quickly did it's kind of an emergency iridotomy where you blow a hole right in the iris. It sounds dramatic, but it's necessary. You punch this hole in the iris, and it allows the fluid to flow normally. And so sometimes you have to act quick. Drops could take a few days to work. She would have lost her vision. Thankfully, in her case, she was a nurse. She understood what the heck was going on with her eye. At least she knew something wasn't right, and she got right to an ophthalmologist. So that's now you can see a little more easily here where the fluid is coming from, and it gets trapped. In her case, it was trapped between the iris and the lens. It couldn't flow through there. So pop a hole in the iris, and boom, the fluid flew right out of her eyeball. It was able to make it into the anterior chamber and then out of Schlem's canal. That's the primary, aqueous outflow of the eye. Okay. You see these pictures of the optic nerve head, the optic disc. You can also get information, an ophthalmologist can, from that. You see in the upper right there, you see the brightly glowing part, and then you see the overall, there's sort of an annulus around it that's less illuminated. The brightly glowing part is called the cup, and then the whole width of all of the sort of bright yellow and orange is called the disc. So cup in the middle and the disc. That ratio, the cup to disc ratio, should be about half. So in other words, this one in the upper right, it's over half. The cup is over half the diameter of the total disc. And so what that means is that over time, decades perhaps, high intraocular pressure has squashed that little sort of ridge around the optic disc, flattened it out, and this is seen by the reflection being much stronger over a wider area. The lower right, it's pretty easy to see there that that cup is roughly 1/2 the diameter of the total disc, and so that's a pretty healthy eye there. Same thing with the lower left. You can hardly see any cupping. So anyway, if they say cup to disc ratio at your ophthalmologist, now you know what they're talking about. All right, this is another thing. Not everybody, I understand, has had a full ophthalmic exam, but one day you probably will if you haven't already. And one of the things you do is you get put in front of this biomicroscope. It's a slit lamp is what it's called, and the ophthalmologist can look very closely at all of your ocular structures. And so, from cornea clear back to the retina. And one of the things they do is your IOP, intraocular pressure. And this involves, oddly enough, putting a device that's, glowing a nice violet color right onto the surface of your eye. And we put numbing drops on there before. And then you dial it in to get the actual pressure. It's calibrated. What you see through there as the technician is a couple of what they're called Myers, but they're lines basically, and when you've got those lined up perfectly after you dial in the pressure, that'll give you look down on the knob that you're adjusting, and it'll give you the actual pressure. Again, it's calibrated. Hopefully it's 15, 18, somewhere in there. If it's 63 like that one gal, then you may be rushed off to get an emergency iridotomy. If not, probably get some drops prescribed for you. And it might be 20. If you're 22, 23, you can lower it 5 or 6 points pretty easily with drops. Another pretty common disease, macular degeneration, and this is usually age-related, and we call it AMD for short. You look at this fundus photograph. This is a picture of the retina, and it's splotchy, for lack of a better term. There's what's called hypo or hyperpigmentation, areas that are pale and areas that are sort of darker. That's not good, and that area right there in the center. It's in the center of your vision. The fovea is kind of in the center there, and of course the nasty part of AMD is that it takes away your central vision. So you go to look at somebody, your grandkids, or tell time or read a book, that part of the world that you're looking at doesn't exist for your vision. And so that's the awful part of it. You have fairly decent peripheral vision, but not central vision. It's the leading cause of blindness now. It's been modified here to people over 60 in the US. So, we've got the baby boomer generation that's, getting into their mid-60s now. And AMD is a big deal. All right, most diseases, in fact, cancers, dementia, Alzheimer's, AMD, they're all a result of cumulative damage. And so how do you limit cumulative damage? There are a couple of strategies. We'll talk about that. I'll try to give you the cure for Alzheimer's disease here in a few minutes, and then hopefully you'll all follow my advice. Progressive degeneration of the central macula, the fovea primarily. All right, people with macular degeneration, they can't read. Again, I mentioned it's the central of your visual field, central part of it. Whatever you look at isn't. Here's what a square grid would look like if you've got the beginnings of macular degeneration. Normally, this would be squared off, and then there's a fixation dot in the center. And you have patients draw either spots, scotomas that are no longer visible dark sort of spots or distortions like this. And you see it starts to look, pretty bad. This is kind of middle stage. In the end stage of it, you're looking at complete loss of the visual field. So you see dark gray patches. So it's pretty bad. All right. Why does this happen? Why does specifically the center of your visual field wear down to the exclusion, or sort of, priority-wise ahead of the rest of the retina? Well, it's because of this. The fovea specifically maintains the highest metabolic rate of any tissue in the body, including the brain. There are millions of reactions happening in your fovea right now if you've got your eyes open, millions per second. So it's an astounding amount of metabolism, biochemical reactions that are occurring. So it therefore requires a lot of nourishment. And how does it obtain the nourishment? Blood. It gets blood. That's the retinal vasculature. This is a rich net of blood supply. I know the guy who drew this picture. It's about 6 feet tall. In fact, it's huge. It's actually, from an anatomical standpoint, it's a beautiful thing. All right, I would not want to draw it. The fovea gets its blood through perfusion. You might be wondering, well, why aren't there any blood vessels there? That comes from underneath, from the choroid, the deeper supply. So there aren't any blood vessels in front of the fovea. We have better vision. So getting at why macular degeneration does manifest in the macula, the center of the retina, it's this high metabolism over decades and decades of life. You're talking about stress, specifically oxidative stress. And so any area of the body, any area, the heart, cardiovascular tissue, retinal tissue, brain, high metabolism and exposure to oxidative products, free radicals, these unstable oxygen species, can damage the tissue. Okay, and after you get to a point where the body can't keep up with it, it doesn't have enough antioxidants in place, then guess what? You're kind of screwed, for lack of a better term, and the tissue starts to degenerate. Okay, these things have their way. The housekeeper can't keep the place clean. The debris, unmetabolized debris, clutters up the area, and so then you get degeneration. How do you treat macular degeneration? Can you treat it? In the early stages, I mentioned this unmetabolized garbage. It accumulates, it clutters up this feeding trough called the retinal pigmented epithelium, and that's I've denoted here as RPE, and that leads to some visual distortion. Okay, so and an ophthalmologist will tell you you've got early macular degeneration. Okay, if you can keep it there, good for you, because you can still, you still have decent vision, usually 20, 25, 20, 30, maybe 20, 40 vision. You can still see and recognize people and read and stuff like that. It's a little bit of a struggle. But later stages, it's referred to as the wet stage. And this is where it's gotten so bad there's not enough nourishment going to the retina. And so the body does this in every case of a lack of nourishment going to tissue. It sends out a signal that says, I need nourishment. I need blood. How does the body get blood to things? Well, it grows new blood vessels in. That's normally a good thing. If you have no blood going to your foot or limited blood, then you grow in a blood vessel and send blood to it, and so you can keep your foot. For the retina, this is not good. The retina is incredibly delicate, and you get blood vessels going in, taking nourishment, blood to it, and it just tears the heck out of the retina, and that destroys it. And so in the center part, it lifts off, it gets chewed up, and you don't have central vision anymore. That causes the blindness. Sometimes you can pinch off those new blood vessels. You can zap them with a laser, and so they stop before they get to the point where they're lifting off the retina and tearing it up. It cauterizes the vessels. It's not, as far as we know, preventable, although I'll give you a preventative measure that will help, guaranteed to help. There are some promising avenues of research, including diet that I'll talk about, and also VEGF inhibitors, vascular endothelial growth factors. That's that signal I told you about. Don't get intimidated by the name there. The signal that goes out, vascular endothelial growth factor, that's the signal that says, send me blood. Okay? If you can inhibit that signal, then you inhibit the growth of blood vessels. Okay? It's this has been shown to help a little with macular degeneration. But again, if you're inhibiting the vessels that are going to the eye, what if there are other vessels that need to be grown in your body and you're on VEGF inhibitors? Well, that can be a little risky. It might be part of your brain that needs a blood vessel a little more in that the body won't be able to grow that in, or at least not as effectively. In terms of diet, I study this thing, macular pigment. Lutein is the primary constituent of it. You get it from your diet, and it accumulates conspicuously right in the fovea. And anyway, you have a lot of this stuff, and I measure it. I know a few of you in my class have had me measure it. You can have anywhere from none, if you don't have any leafy greens in your diet, to a ton of it. The body can put an amazing rich concentration of lutein, this macular pigment, in your fovea. It also goes into your brain, where it does the same stuff as it does in the eye, namely limits oxidation. Okay? So again, as I mentioned, it's obtained solely from the diet. Leafy greens, spinach, kale, broccoli, a lot of the stuff that you guys love to eat. They contain lots of lutein and zeaxanthin. These are the constituents of macular pigment. All right, and the brain loves particularly lutein. I told you I'd give you the cure for Alzheimer's. You get this stuff in your body and let it do its work. It stays in there. You don't have to constantly eat this stuff. I mean, you can build it up, and then it's robust. It'll stay in there and do its work for decades of your life, limiting that cumulative damage. That cumulative damage, again, manifesting as cancer, age-related diseases like macular degeneration. All right, see that yellow tint in the middle there? That's somebody with a fair amount of lutein and zeaxanthin in their retina, these carotenoids. Okay, macula lutea means yellow spot. And check this out. Here's a cross-section of a retina. You see that dip there? That's the fovea. You see the rich concentration of yellow in the top one there. It absorbs preferentially blue light. You see where it turns black under blue illumination. That is really great. I mentioned before, blue light has higher energy per quantum than other forms of light, like green. You see in the bottom there, it transmits all the green. And so lutein, macular pigment, is helping the retina, protecting it in two ways. All right, so it's a carotenoid. It's an antioxidant, one of the best antioxidants there is. Quenches those nasty free radicals. That's a good thing. It also limits exposure to the retina of high energy, too high energy light. And so it does those two functions. Over the lifetime, again, cumulative damage is limited. Morbid thought for the day, we actually rust to death. It's the oxygen paradox. We need oxygen to live, but ultimately it's oxygen that kills us. And again, a little morbid. I apologize, but it's the truth. If you can limit this rusting by having antioxidants in place through your diet primarily, then it's the way to go. Do it. I command you, eat your vegetables. All right, diabetic retinopathy. Diabetes can be really nasty. It really it impacts vasculature, small blood vessels primarily, and then ultimately larger blood vessels as well if you don't keep it under control. As of course, as we saw, the retina has a net of small blood vessels, and so of course the toxicity of glucose, blood sugar, the being so high in these vessels, it damages the smaller ones first. They break apart, they leak into the retina. Diabetic retinopathy in some ways is like macular degeneration because it results from a lack of nourishment, and the body will in fact grow in new vessels, and that tears up the retina as I've described earlier. Okay, you can zap these vessels. You see in the left fundus photograph, you've got those little white flecks. Those are little photocoagulation spots where there's been a laser that's zapped an area that's zapped a blood vessel, I should say, that's preventing that vessel from growing into an area, the fovea there. Okay. All right, so keep your blood sugar under control. Okay, you can do a lot of damage if not. How do we test? In the ophthalmologist's office, we use what's called fluorescein angiography. You actually inject, sounds a little crazy, but you inject a fluorescent dye into the bloodstream, and then about 10 seconds later, you take a picture. And if you've got a nice healthy eye, like in the lower left there, or the upper, well, yeah, I guess lower left is really the only one. I guess the upper right's not bad either. If you've got a normal healthy eye, you see the blood vessels light up. They fluoresce, okay, with a special filter on the camera. If you have diabetic retinopathy, the lower right there, you see the blood leaking into the retina, and the whole retina appears to glow because there's blood that's leaking into it. Okay, all the fluorescein, that fluorescent dye is leaking into the retina, so that's not good. So you test for that, and that gives you a general state of, the status for, the retina in terms of progression of diabetes. So diabetics will often, if they're having what's called a diabetic attack, hyperglycemic attack, they'll, a couple of things. They get very thirsty. That's a sign that their blood sugar is way off, is way high, or vision will become blurry. And why is this? There are some of an effect actually with the electrical changes in the retina, but that's kind of a relatively small effect. The biggest effect here is that is called osmolarity, and it's the concept of water following sugar. And so what happens is sugar from the blood, it actually gets into the lens as well. And so sugar enters the natural lens, your crystalline lens. It gets changed into this substance called sorbitol. And then sorbitol cannot exit the lens as easy as sugar. But sorbitol attracts water, just like sugar does. Okay, this is the reason you get so thirsty when you've got high blood sugar. Okay, your body, the signal is like, I need water, I need water. Okay, it's got to follow that sugar. Well, of course, now in the case of the lens, water goes into the lens, okay, in a much higher concentration than it normally does or should. The lens takes on water. That makes the lens bulge. It changes its focusing power, and that causes blurry vision. Simple as that. So there you go. See how much you're learning? I hope you're learning something, maybe a little bit. Of course, diabetes related to this obesity epidemic that we're going through. These slides are illustrative of the epidemic. And these data I'm going to present are from the CDC, defining body mass index, basically a ratio of your weight in relation to your height. And a BMI is defined as 30 or higher. Now, somebody who's 5'4" and 30 pounds overweight, you might not look at them and say they're obese, but this is how, that's not the point here. The point is that the CDC kept that as a strict criterion throughout this study. Started way back in 1985, and it's gone through, I'll show you data from until 2010. And you see the white states here, not everybody, not every state is participating, but many are, including Georgia. And I apologize for the numbers being a little bit off there on the bottom, but the darker blue, 10 to 14% of the population maintaining a BMI of 30 or greater. The light blue, less than 10%. Okay, and again, the white state's not participating. Okay, you'll see some things shift. Georgia went under 10. We must have been right on the line. 7, you'll see some states start to participate. You'll see a slight dark the United States. Okay, again, 10 to 14%. We would be happy to be right here, 1990 and 2014. Okay, category, 15 to 19%. You'll see Mississippi leading the way. There's Louisiana, Michigan. 2. More dark. 6. Okay, it's starting to get darker. Now, mind you, contagious diseases don't spread this quickly. All right, is obesity contagious? No, in a sense, maybe. Yikes, new category, greater than or equal to 20%. Indiana, there's again Mississippi, Kentucky, 98. Whoa. Okay. Starting to spread again like wildfire. What is going on? Why is everybody getting bigger? Mississippi leading the way. Greater than or equal to 25% of the population at BMI of 30 or more. Yikes, 2000. Oh boy, Texas joins the belt. Oh no, a new category, greater than or equal to 30%. Roughly 1 out of every 3 people in these states with a BMI of 30 or greater. That's 2006. And 2010. Yikes. Again, a pretty scary situation. Of course, obesity can very often lead to diabetes. This is why there is a healthcare epidemic in the United States, primarily. I've spoken with some folks at the CDC and the government that say, well, if we could, eliminate smoking and obesity, we wouldn't have. It would reduce the healthcare budget by over 60%. Just those 2 things. So think about that. And so this is all about prevention. Those are completely preventable, right? You can quit smoking. I know it's hard, but in obesity, certainly, we can deal with that. You go back to 1990, and the map looked much different, right? So anyway, there's my soapbox on that. I will say as well, Mississippi in 2010 was at 34.9%, so very nearly on the cusp of a new category for Mississippi, 35%. So anyway, stuff. Finishing up on the clinical end of things here, we've got a couple of things. Sometimes students ask me about retinal detachment, and wow, what happens there? Well, often it's a physical trauma. All right, so you've got possibly in a sports game, maybe a ball will hit you in the eye, something like that. You didn't see it coming, or if you get punched in the face, God forbid, sometimes it'll catch your eye and the retina will detach. Sometimes they're spontaneous and sort of what's called idiopathic. We don't know why, we don't know where it came from, but often it's injury. And you see up here in the top left where the retina is sagging away from the back of the eye. And so, yikes, it can't send signals. Of course, vision gets distorted and you have a big blind spot. What do you do to treat? Well, a couple of things you can do. The first is quite painful. I've actually seen both of these techniques in the ophthalmology office, called a scleral buckle. And strangely enough, my graduate school advisor, a vision scientist, his wife has an unusual condition where she actually acts out her dreams, and she does not have, her muscles aren't shut down. She doesn't have atonia during REM sleep. So she actually flails around, and apparently one night she just forearm, shivered Ken, my advisor, just came across the bridge of his nose, whammo, with her forearm, gave him retinal detachments in both eyes. And so thankfully he lived across the street from an ophthalmologist, and the next morning realized that he had detached retinas. Went in, they attach a buckle, a clip, basically around your eye and very gently squeeze while looking inside your eye and making sure they've got it lined up just right. They push the eyeball back towards the retina and they kind of squeeze it. And again, this is painful, as described by Ken anyway, and he seemed to be a fairly tough guy, but oh man, that sounds brutal to me too. He said it was unbelievably painful. For about an hour, you hold that buckle in place, the retina gets pushed back up against the wall of the eye, and it reattaches. And then you take the buckle off, and you're good as new. Okay, the cells know where they're supposed to go, they line up, they reattach. Another way to do this, and I've seen this technique, it's very rare, it's fairly expensive, is to actually inject an air bubble into the eye. Okay, you have to release some fluid so you don't increase the pressure too much in the eye. But you have this air bubble that if you tilt your head the appropriate way towards the opposite direction of the detachment, you've got buoyancy on your side and it pushes the retina back into place. Okay, certainly more involved, again, like I mentioned, expensive, less painful, but effective. Takes a little longer. It takes a couple of hours because the buckle maintains better pressure, I guess, overall. You can't actually see that bubble that they've got depicted there. It's not that big, usually a little bit smaller, about half that size. And the buoyancy itself is not a incredible pressure, but it holds the retina in place long enough. You have to sit there with your head in that position for a few hours. So it's a bit of a pain, but a little taxing, but worth it. You get your retina back attached and you can see properly again. So, all right. Well, that does it for the clinical aspects of vision. Hopefully you've learned something. I know a lot of these terms that I've probably said might not be in the slideshow itself. Don't worry so much about the terms. Some of the basic concepts you should be familiar with, and certainly the terms that I've spelled out here in the presentation are important to know. So anyway, email me with any questions. I'll post the slides on color vision here shortly as well. Hope you guys are all right. I'll see you as soon as I possibly can, I promise. The madness will stop soon. Okay, take care.